I think it is really an honor to speak at this. Actually, when I was just waiting there, I was looking at the fact sheets and two things. Firstly, I think all the past speakers they were showing on the video, really, it's a lot of people I have a lot of respect for, and some of my very good friends were previous speakers, so it's truly an honor to be here. I think the second thing that I would say is that it says make hepatology education or make education accessible anywhere. And this is really very practical for me because what I was telling Dr. Sanjaya is that I actually watch these videos on the train on my commute to work every day, and they've really been very helpful. And really, you can access it anywhere. So, really, I think it's a privilege to be here. I'm Mark. I'm one of the transplant hepatologists from the National University Hospital in Singapore. And today I'll be talking about pulmonary complications of liver cirrhosis. These are my disclosures, none of which are relevant to this talk. However, I will cover the off-label use of treatments, again, none of which I have any conflict for. So I think the outline today I will cover is mainly I will focus on portopulmonary hypertension as well as hepatopulmonary syndrome. I will touch a bit on hepatic hydrothorax and spontaneous bacterial empyema, just a bit on it. I will not be covering hemorrhagic hereditary telangiectasia. So the outline will go on for each of these topics. We'll talk about epidemiology, pathogenesis, clinical features and diagnosis, prognosis and management challenges, transplant-related issues. For the first two topics, PoPH and HBS, I have two cases I've selected, and these are not standard cases. These are cases where I personally feel that our team has struggled with, that we have things to learn from, and we're very open about our struggles because we truly believe that we learn from the difficult and challenging cases. So we'll move on. So firstly, portopulmonary hypertension. What is the epidemiology of this? Now, in this meta-analysis that was recently conducted, we see a highly variable prevalence of the disease among a cirrhotic population. So while the pooled effect was about 2.4% in the cirrhotic population, you see it can be highly heterogeneous, with one study even reporting up to 30% in a cirrhotic population. So among these 48 studies, you basically see that the prevalence based on right heart catheterization is 2.4%, but the prevalence based on echocardiography is 8.7%. So it's really more based on right heart catheterization. But I would caution you when approaching the prevalence data, it can be quite inaccurate because the reality is what is important is this from a transplant center or not? Because patients that are managed at transplant centers or transplant patients, as we'll discuss further on down the road, the physicians are more sensitive to the diagnosis of portopulmonary hypertension. The second thing is it a tertiary referral center? Now, if you come to my center, you'll find a much higher prevalence of portopulmonary hypertension just because we have a strong structural heart disease team. And because of this, we get a lot of these patients who referred in for their right heart catheterizations and they end up with us. So if I report my prevalence, it's going to be higher than the 2.4% among our cirrhotic populations. So really consideration must be taken into the type of center where the data is coming from. Among transplant patients, we see a higher epidemiology, 8.5%, as mentioned, because as transplant physicians, we need to be very sensitive to this because of the implications in transplantation. So biased by increased awareness, screening policies. And however, a recent study from the Mayo Clinic demonstrated a 0.7 prevalence in successive liver transplant referrals. Of course, this may be because the Mayo Clinic, really a leader in this field, has been publishing quite actively, and they've trained so many people that people are now managing it in their institutions rather than sending it to the Mayo Clinic. But again, this is just a conjecture. Now, what is the relevance in patients with portopulmonary hypertension? These patients have poor survival. There's a 5-year survival of less than 50%, and these patients have worse outcomes than idiopathic pulmonary arterial hypertension. So we see 5-year survival less than 50%. So really quite a poor survival, and even worse than idiopathic pulmonary arterial hypertension. So what are the implications? These survival rates that we see are 84%, 69%, and between 40 to 51% at 1, 3, and 5 years, based on a number of registry studies. They have worse survival outcomes than regular PAH or cirrhosis patients, as mentioned before, because you can say that they have more problems. And their traditional data shows higher mortality after liver transplantation. And what is very important is in a recent survey done and published in Liver Transplantation, we actually see that there's a high variability in treatment approaches among hepatologists, really very highly variable. So what is the pathophysiology of the disease? So let's first talk about the pathophysiology of pulmonary hypertension and what are the types of pulmonary hypertension. So pulmonary hypertension describes a group of severe pulmonary vascular disorders characterized by elevated mean pulmonary artery pressures at rest, or MPAP at rest. Patients with pulmonary hypertension are divided into 5 groups based upon the etiology and mechanism. Okay, so patients in group 1, which I'm going to highlight here, are considered to have pulmonary arterial hypertension, which has several causes: inheritable, drugs, connective tissue disease. And portopulmonary hypertension falls under group 1 pulmonary hypertension. Group 2 is due to left-sided heart disease. So we always say the most common cause of pulmonary hypertension or right-sided heart disease is left-sided heart disease. I learned that in medical school. And so really these are more common. This is a lot more common. Then group 3 is due to chronic lung disorders and hypoxemia. Group 4 due to CTEPH obstructive pulmonary artery diseases. And group 5 are due to undefined mechanisms considered to have pulmonary hypertension, such as hematologic and systemic disorders. But the one that we are concerned about is group 1, or type 1 pulmonary artery hypertension, which is where this is pulmonary arterial hypertension, not pulmonary venous hypertension, which is where portopulmonary hypertension lies. What is the pathophysiology? The pulmonary arteries are comprised of 3 layers. The inner intima media, if you can see it on this diagram, the middle layer comprised of pulmonary artery smooth muscle cells, and the outer adventitial layer comprised of mainly fibroblasts. Abnormalities in the function of all these cells have been implicated in the development. So you can see this figure, you can see proliferation, but I summarize it for you into 3 things. There's vasoconstriction, thrombosis, and remodeling of the arteries, leading to increased pressure and increased pulmonary vascular resistance, and that is key. So this is for pulmonary arterial hypertension. Now, what is the pathophysiology of portopulmonary hypertension? So portopulmonary hypertension develops when the portal hypertension allows vasoactive substances to bypass hepatic clearance and reach the pulmonary circulation. This leads to endothelial dysfunction. The increased vasoconstrictors, so particularly endothelin 1, together with reduced effective vasodilator signaling, promote sustained pulmonary arterial vasoconstriction. And we must remember that in cirrhosis, this is a hyperdynamic high-flow circulation. The chronic endothelial injury drives pulmonary vascular remodeling with medial hypertrophy, intimal fibrosis, and smooth muscle proliferation. So really, it is what is coming through from the liver that is affecting the pulmonary circulation. Not in all our cirrhotic patients, as mentioned, in between 2 to 5%. So what is the diagnosis and differentials, and how do we make a diagnosis? We start off with clinical presentation, usually progressive exertional symptoms, peripheral edema when late, but of course in a cirrhotic patient we'll always be looking at peripheral edema, so hard to tell from there. Incidentally, during echocardiograms done for liver transplant evaluation or other causes, and of course clinically you can have a loud P2 or primary component of the second heart sound, as well as lower limb edema. So how do we diagnose this, or what are our echocardiographic clues? So let's say we have symptoms and you have a low threshold for sending your patient for echocardiogram. In all our transplant protocols, we generally do an echocardiogram. So what we're looking for is a tricuspid regurgitant velocity of greater than 2.8 m per s. So we look at the tricuspid regurgitant velocity. Now, other than the TR velocity, we also look at certain features. Now, I'm not a cardiologist or an echocardiographic, but we do look at this. So we look at the ventricles, the pulmonary artery, as well as the IVC and the right atrium. And these are the features that people look at because you don't always get a tricuspid regurgitant jet. Now, your echocardiographic clues correlate quite well. So I have highlighted it over here that correlating to a mean pulmonary artery pressure of 20, which is the new definition of pulmonary hypertension. It has an AUC of 0.936. And for 25, an AUC of 0.933. So really relatively high. So really quite a good tool to pick it up. Oops. Now, one thing I want to mention is the right ventricular systolic pressure or pulmonary artery systolic pressure cannot be reliably estimated if the TRV cannot be measured. And this can happen if there's a poorly visualized TR jet. In some of our patients who are obese, especially our patients with meso and ascites or lung disease, other lung diseases, they have suboptimal acoustic windows and you cannot pick up this TR jet. And there can also be technical factors. And if you have this, if you don't, your PASP or your RVSP may not be estimated. And if it is not estimated, then you don't realize that the patient has pulmonary arterial or suspect. So really your clinical index of suspicion must be there. And if you suspect this patient has it, even if you cannot estimate that, you should consider sending this patient for a right heart catheterization. So what is the diagnosis of portopulmonary hypertension? So there's a new criteria now. There's an old criteria prior to 2023, but I'll focus on a new criteria. So mean pulmonary artery pressure of more than 20 millimeters of mercury, a pulmonary artery wedge pressure of less than 15 millimeters of mercury. And we'll go through exactly what this is. Then we have a pulmonary vascular resistance of more than 2 Woods units or 160 dynes. To convert between Woods units and dynes, you just multiply by 80. And the presence of portal hypertension or a wedged hepatic vein pressure. So what exactly are we doing or what exactly are we measuring? So if you can see here, if you can look at the top right, I've drawn here, I've taken this image. So you can see this is the catheter going into the right atrium, right ventricular, into the pulmonary artery, and deep into the pulmonary artery, you can see, sorry, I'm drawing wrongly. It dips into the pulmonary artery and then you wedge it. Now, when you wedge it into the pulmonary artery, it gives you an estimation of the left ventricular pressure. So in portopulmonary hypertension, you have high pulmonary vascular resistance. So this high pulmonary vascular resistance is key to the diagnosis because remember, we have all the proliferation, vasoconstriction going on in the pulmonary arteries. However, the post-capillary pressures are low or the wedge pressures are low. Why is this the case? Because the wedge pressure is estimating the left heart pressure. And if that left heart pressure is low, it means the left heart is not a problem. It is not forcing back on the catheter. The main problem is actually coming from the pulmonary vascular resistance. So it's coming from the pulmonary vascular resistance. So if you think about it, if you have a traffic jam, is your traffic jam coming from a more distal place or a more proximal place? So that is the thing. So again, and there's some maths that we have to look at if we truly want to understand this. So what is the pulmonary vascular resistance or PVR? This is the mean pulmonary artery pressure minus, so it's the mean, so the mean pressure minus the wedge pressure divided by the cardiac output. The diastolic pulmonary gradient is the difference between the diastolic mean pulmonary artery pressure and the pulmonary capillary wedge pressure. And we'll go through this, why this is important later. Finally, the equation to remember, mean pulmonary artery pressure equals to PVR times CO plus PCWP. So your pulmonary vascular resistance multiplied by your cardiac output plus the PCWP. So your mean pulmonary artery pressure is your definition of pulmonary hypertension. But based on these numbers, you want to find out why you have pulmonary hypertension. And your biggest confounder is group 2. So we look at the differential diagnosis or the common diagnosis associated with this. And firstly, you can have a hyperdynamic circulatory state. Why is this the case? And in cirrhotic patients, so you have an increased cardiac output, but you'll have a low pulmonary vascular resistance and an increased mean pulmonary artery pressure and a low pulmonary capillary wedge pressure. So this tells you that your patient has a high cardiac output. And if you go back, you see the high cardiac output will give rise to a high mean pulmonary artery pressure. I will go through each of these in more detail for greater understanding. So let's talk about liver patients. Liver patients have a high cardiac output. Why do liver patients have a high cardiac output? Hyperdynamic dynamic circulation, vasodilation, reduced effective arterial blood volume. So as such, cardiac output is increased. So if you look at this, cardiac output goes up. So if your cardiac output goes up, your mean pulmonary artery pressure goes up. But in essence, your pulmonary vascular resistance is low. So if we look at this, what do we see? What do we see? Your patient has a low. So what are the metrics that you measure? Your mean pulmonary artery pressure is elevated. Your pulmonary capillary wedge pressure is low, and your pulmonary vascular resistance is low, and your cardiac output is high. So in this kind of patient, and I've written the typical numbers that we see here, if you're thinking about a transplant evaluation, this patient can actually proceed with transplant. In fact, the patient's mean pulmonary artery pressure may even improve with a transplant because you're getting rid of the primary problem, which is that reduced effective arterial blood volume hyperdynamic state. Then we have patients with left heart issues. We now see a lot of patients with cardiovascular disease. And what is called in these patients, the mean pulmonary artery pressure, if you can see here, the MPAP is driven by the MPAP is driven by the pulmonary capillary wedge pressure. And that is a marker, remember, of what I said coming from the left heart. So in these patients, although the mean pulmonary artery pressure is high, the pulmonary capillary wedge pressure is also high, meaning what is being transmitted from the left heart is also high. So it is actually left heart dysfunction. In these patients, you can look at the diastolic pulmonary gradient. Why you look at the diastolic pulmonary gradient? Because if it is less than 7, it is purely left heart. But remember, a patient with MESL with left heart dysfunction can also have portopulmonary hypertension. And if the diastolic pulmonary gradient, which is the mean pulmonary artery pressure minus the pulmonary capillary wedge pressure in the diastolic mean PAP minus pulmonary capillary wedge pressure is greater than equals to 7, this tells you that there's both pre and post capillary, or both alludes to both increased pulmonary vascular resistance plus left heart disease. So in this kind of patient, your question will be, will cardiac disease contraindicate this patient for liver transplantation? Because this patient may have very poor cardiac disease. So really need to sit down and think, would the patient benefit from a liver transplant? Now, in this case, sorry, I've written the title wrongly. This is actually pulmonary arterial hypertension coming from non-portal hypertension cases, meaning primary pulmonary arterial hypertension. For example, a patient I had with scleroderma. So what you see is these patients have a mean pulmonary artery pressure of more than 20 millimeters of mercury, elevated pulmonary vascular resistance, a low pulmonary capillary wedge pressure, exactly like your portopulmonary hypertension patient, but a hepatic venous pressure gradient of less than 6 millimeters of mercury. Now, as a standard, when we are having cirrhotic patients going for right heart cath, we always get our cardiologist to do a HVPG measurement at the same time. Then you need to ask yourself, is this truly portopulmonary hypertension or truly just plain primary pulmonary arterial hypertension? Do they have something else that is driving the primary pulmonary arterial hypertension? So other causes of group 1 pulmonary hypertension should be considered, and this patient should not be transplanted because, and you really need to be very clear, if this patient has a low HVPG, should they be transplanted? Finally, what we are talking about, portopulmonary hypertension. In these patients, we see exactly like previously, a mean pulmonary artery pressure of greater than 20 millimeters of mercury, a pulmonary vascular resistance of greater than 2 Woods units, and a low pulmonary capillary wedge pressure. So again, it's not coming from the left heart, it is all coming from the pulmonary vascular resistance. So all driven by the pulmonary vascular resistance. So if you can allude to what I've been saying and highlighting, this is all due to pulmonary vascular resistance, that very high resistance flow through the pulmonary circulation or the pulmonary arteries primarily. And so you really should that is the concept behind all of this, and this patient has an elevated wedge pressure measurement. And so we'll discuss the management further. Now, how do we grade the severity of portopulmonary hypertension? We grade it based on the mean pulmonary artery pressure. Although personally, I look very much at the pulmonary vascular resistance. So mild is between 20 to 35, moderate is between 35 to 45, and severe is more than 45 millimeters of mercury. So this is the severity scale. So what is the prognosis and what are some of the management challenges we have? So patients, and I've previously discussed, patients with PoPH have really poor survival. So we need to treat them. And what treatments do we have? We have a number of treatments that target the nitric oxide pathway, the prostacyclin pathway, and the endothelin. So what are we trying to do? Relax the pulmonary arteries. And so you have endothelin receptor antagonist, you have guanylyl cyclase inhibitors, you have basically a number of agents that I have listed out here that relax and reduce proliferation and inhibit constriction and proliferation. And we'll go through some of them. So sildenafil or PDA5 was evaluated before, and basically we see sustained responses. And you generally see that we see a benefit, a relative benefit in patients with sildenafil, a benefit in mean pulmonary artery pressure. You can see from 57 to 49, 48, 36 to 20, 47 to 38. So a general improvement and an improvement in the mean values at 3 months and at 12 months. You also see a drop in the pulmonary vascular resistance. This is in dynes and not in Woods units. So you divide by 80 to get the Woods units. Now, I think this is the landmark study. You cannot have a discussion without looking at this. This is the landmark study on the Portico trial, or the use of macitentan for the treatment of portopulmonary hypertension. So this is a phase 4 study. And of course, we see the endpoints for pulmonary vascular resistance, comparing the baseline and comparing, and as well as the change from baseline. So you can see that macitentan had a significant increase or significant benefit in the reduction of pulmonary vascular resistance as compared to placebo, as well as this is the effort tolerance. So really macitentan has been shown to be a very good agent. So we have generally 3 endothelin receptor agonists, bosentan, which is liver toxic, so we generally don't use it, ambrisentan, and macitentan. In my center, we generally use ambrisentan because it's a fair bit cheaper than macitentan. However, various patients have various options available to them. Now, we do see in this more recent study that combination therapy between endothelin receptor antagonists as well as phosphodiesterase inhibitors, PDE5 inhibitors, generally combination therapies are superior to individual therapies alone. And both in terms of mean pulmonary artery pressure and cardiac output, as well as pulmonary vascular resistance and 6-minute walk time. These are all in patients with portopulmonary hypertension. So, and I think when you look at it, the summary is from this study. I think this is quite a nice cohort study looking at all of this. And really what we see is that if you look at it, even in D, figure D, which is over here on the right side, you generally see that any treatment is better than no treatment. So you see on the top left, they had PDE5 inhibitors. Here you had ERAs. Here you had combination of, so it's either PDE5 or ERA, and here is any known treatment like prostaglandin, prostacyclins for portopulmonary hypertension. And you see, any treatment still is more beneficial than no treatment. So this is treatment in survival. So now we talk about transplantation. So now when we look at patients with portopulmonary hypertension, the reality is that the liver issue is driving the pulmonary hypertension. And so the hope is that by transplanting them, you will not only solve the liver cirrhosis, but you will also benefit the issues of the pulmonary hypertension. However, mortality is higher in patients transplanted for portopulmonary hypertension as compared to patients without portopulmonary hypertension. So what were the risk factors for mortality in these patients? So elevated mean pulmonary artery pressure and elevated pulmonary vascular resistance. So these generally showed us that, so again, the more severe the portopulmonary hypertension, the worse the pulmonary vascular resistance, the worse the survival. However, we realize that if you select your patients carefully, what can happen is that you actually can achieve relatively similar. So in these two studies that I've put here, so this first one by Oliver Sitburn, you basically see that these patients had a mean pulmonary artery pressure of more than 35 millimeters of mercury, and they had repeated hemodynamics after vasomodulator therapy. So 35 patients who succeeded with vasomodulator therapy, meaning ERAs, PDE5 inhibitors, to bring down the mean pulmonary artery pressure. And look, 6 months survival, 80%, 1 year survival, 77%, 3 year survival, 77%. So better than the quite abysmal survival that we saw previously. And really, I think this one is more encouraging, where we actually see that patients receive intravenous vasomodular therapy during the perioperative period, and their survival rates were 85.7% after a median follow-up of 7.8 years. And they were able to wean off the vasomodulator therapy. So really, I think with selection and bridging, we can bridge these patients to transplant. So what is the algorithm for transplant? So basically, once you do a transthoracic echocardiogram, if they have elevated PASP or RVSP, and you do a right heart cath, high mean pulmonary artery pressure, you need to ask yourself, which we spend quite a bit of time figuring out, is this portopulmonary hypertension? Now, if they have moderate to severe portopulmonary hypertension, we can treat them with pulmonary artery hypertension targeted therapy, repeat a right heart cath. So again, moderate to severe, again, is at least 35 millimeters of mercury on the mean pulmonary artery pressure. And you repeat it. If it's gone down to mild, you can actually bridge them to transplantation and consider a mild exception. In my country, they would get a mild exception of 16 points. Mean pulmonary artery pressure, if it's 30 to 45, if the pulmonary vascular resistance is high, then again, we'll consider escalation of therapy. If you started sildenafil, you may want to add on an ERA. If you are on an ERA, you may want to add on sildenafil or PDE5 inhibitor, so on and so forth. And if it's more than 45 to 50, it'll be contraindicated, high risk of mortality, and consider escalation of pulmonary artery hypertension therapy and defer liver transplantation. So I think the cutoff for treatment. So if you initial diagnosis, if it's more than 35 millimeters of mercury or elevated more than 3 Woods units, you should consider therapy. And if it is less than 35 and less than 3 Woods units, then you should consider. Now, my own center doesn't follow the first line. We would not take a patient with 5 Woods units. We're very sensitive to the pulmonary vascular resistance. And so because of that, we have a strict criteria for PVR of less than 3 Woods units before we proceed with liver transplantation. And of course, a repeat right heart cath every 3 months to demonstrate persistent hemodynamic response because, these patients are waiting on a transplant wait list. So what are the outcomes with transplant? So basically, if we see patients, when you compare pharmacological therapy to patients of pharmacological therapy plus liver transplant, you realize that you have a significant survival benefit with liver transplant. Because, for all that we said, why don't we just give the patient macitentan and let them continue? They have a significant benefit if you bridge them to transplantation. And 100 in this study, 100% were able to discontinue parenteral vasomodulator therapy after transplant at a median of 7.2 months. And this is parenteral, and 61.9% were able to discontinue all vasomodular therapy, including the oral like macitentan, ambrisentan, at a median of 13.9 months. Now, one of the things I want to bring up is where are these patients? Why are we so scared of doing transplants at them? And the key is in reperfusion. And I've taken this from the UCSF liver transplant anesthesia liver transplant resident handbook. They had it on the internet. It was, and if you look at your mean PA pressure across all your stages, you see it rises significantly during reperfusion. So imagine if you've done a clamp, especially nowadays, they don't do total cross clamp, they do a partial cross clamp of the IVC. But sometimes, for certain surgical reasons, tumor invasion, or if they need to do outflow reconstruction, they may end up doing a total cross clamp of the IVC. Now, if total cross clamp higher risk. So what happens is now your right heart which is already dysfunctional because the pulmonary vascular resistance has given rise to an abnormal right heart. And then because of the pulmonary vascular resistance on the right heart, then what happens is that you are at risk of having right heart failure. Now, sudden fluid overload or sudden inflow. So the volume overload into the right heart increases significantly, and the patients can arrest during reperfusion. The second thing I want to say is right heart failure is not easy to pick up. A lot of us are very familiar with left heart failure. We see left heart failure very common, but right heart failure is really quite challenging to pick up. So what are the perioperative issues? So I think this nice guideline in liver transplantation has summarized it. So what can you do? Controlled induction, use of vasopressors or inotropes based on RV function. You always do this operation. Your anesthetist should do the operation with a transesophageal echocardiogram, judicious volume resuscitation, and consider the use of veno-venous bypass. I'll discuss this later. Hemodynamic management and of course early consideration for VA ECMO for patients who decompensate. If you're struggling and your patient has right heart failure. How about weaning it post-transplant? Patients post-pol should have an echocardiogram and clinical evaluation. And basically, in summary, it is very, very variable. No one has any guidelines for how to do it. My own center, we monitor BNP, close monitoring with the cardiologist in the first year post-transplant. And after we monitor with the cardiologist, and then in the first year post-transplant, then after that, we evaluate when we want to slowly taper from 2 agents, slowly lower the dose, take off 1 agent, slowly lower the dose. And of course, you need a center with expertise. The other thing in my center, a lot of these drugs are not covered by our government. So macitentan is not covered. It's $9,000 a month. So again, this is one of the challenges. So we generally try and wean off the ERAs rather than the PDE5 inhibitors first. So I'll bring up a case discussion. So it's a 52-year-old Chinese male from my center. So again, caveat, I have pulled up a case with a slightly bad outcome from my center, and because I believe we learn from bad outcomes. So this is a 52-year-old Chinese male, 67 kilograms, BMI 23, previous alcohol smoker. He's a hawker, so really cooks very good food to eat. And this is his past medical history. Of note, he had GI angioectasias with GI bleeding. On hindsight, this may have been due to his pulmonary hypertension or portopulmonary hypertension. So he was diagnosed with cirrhosis, presented with variceal bleeding, had a new onset ascites, diuretic intolerance due to hypotension, had an MRSA infection and decompensation as he progressed. We initiated the transplant evaluation and we picked up that he had multifocal HCC along the way and no option for surgery. So maybe I'll just caveat here. He had 5 lesions, but he was within UNOS DS. We are Living Donor Liver Transplant Center. So if they are dual PET negative, PET acetate and PET FDG, low AFP, we may still consider proceeding with liver transplant for these candidates. I'm not here to discuss the controversies of HCC management, but this patient, if there's a living, he's not a candidate for deceased donor transplantation, but living donor transplantation, he could be a candidate. So he had an AFP of less than 5, and both dual PET were negative, FDG and acetate PET. So this was a summary, esophageal varices, recurrent variceal bleeding. So, and when we did his transplant workup, what did we find? A diagnosis of pulmonary hypertension. PASP was 52 millimeters of mercury. We did a right heart cath. His pulmonary capillary wedge pressure was 12, less than 15, as we mentioned. Mean pulmonary artery pressure was 45, so in the severe range, and the pulmonary vascular resistance was 5.8. So his spirometry showed unlikely group 3, pulmonary angiogram, normal pulmonary arteries, no CT-EPH, and LV function was preserved, and no rheumatological issues. So we started ambrisentan for him, not macitentan as per the study, but ambrisentan. We repeated ambrisentan over PDE5 inhibitor because it was quite severe. We repeated a right heart cath and we see a significant improvement. His mean pulmonary artery pressure dropped. Pulmonary capillary wedge pressure also still remained low, but the pulmonary vascular resistance also dropped to 2.15. So he had a good response to vasomodulator therapy, cleared for living donor liver transplant, repeat imaging, the tumors had not grown, still within UNOS DS, no rise in the alpha fetoprotein. So this was it, and he basically had portopulmonary hypertension. So what happened is at reperfusion, and we did not use veno-venous bypass, which on hindsight we should have. The patient had cardiac arrest on table due to combination of reperfusion injury and RV failure. So his BP started downtrending. And this is what I wanted to highlight. When you go into theater with these patients, you have to be prepared. You have to remember, and we strongly value the use of VV bypass in these patients. And so thankfully, our anesthetists were excellent, downtime of 3 minutes. They were able to resuscitate him. TEE after EF was 30 to 35%. And so, yeah. So post-transplant, the patient had vasoplegia, completed 5 days of imipenem. So it was a stormy post-transplant stay. He had delirium post-transplant, but it slowly resolved. And finally, ambrisentan was restarted. Sildenafil, we also put it on, but we didn't want to put it on because we were worried about the mentation, so the CNS perfusion. He was discharged slightly less than 2 months post-transplant, and he had a prostatitis post-transplant serial echography. We've demonstrated, so the EF picked up. The PASP was relatively, so this is in the first 2 to 3 months post-transplant, where we're continuing the vasomodulator therapy. So he had significant functional improvement, was able to return to work and continue on sildenafil and ambrisentan. So, and managed to wean off the VM therapy. Now, I will switch to hepatopulmonary syndrome. So that's all I have for portopulmonary hypertension. So now for hepatopulmonary syndrome, it occurs in 5 to 30% of patients with liver cirrhosis, mainly again from transplant centers. That same bias that we spoke about, because in transplant centers, people are actually looking for it, and presence and severity do not appear to correlate with liver disease severity. This is very important. Similarly for portopulmonary hypertension, because these patients, their mortality outweighs their MEL scores or their synthetic dysfunction. And so because of that, they are underserved by our traditional cirrhosis severity scores. So this is why we give them MELD exception points. So it's characterized by a defect in arterial oxygenation induced by pulmonary vascular dilation in the setting of liver disease. They have intrapulmonary vascular dilatations and AA gradient of more than 50 millimeters of mercury or 20 in elderly patients. So there's two types. Type 1 has a normal angiography and type 2 has focal AV malformations. And you must have hypoxia because these intrapulmonary vascular dilatations may occur asymptomatically without gas exchange impairment. So you must have a gas exchange impairment in patients. So to think of it, right, I think this article summarizes it nicely. Spider nevi of the lung. That's essentially what it is from 1966. So basically, the definition, you need to have oxygenation issues. So an AA gradient of more than 15 millimeters of mercury or more than 20 in more than 65-year-olds. Type 1 respiratory failure or PaO2 of less than 80 millimeters of mercury. And you need to have a pulmonary vascular dilatation as evidenced by a contrast-enhanced echo with air bubbles or a normal uptake in the brain with radioactive lung perfusion scanning. And the presence of liver disease. So three things. What is the pathophysiology? So basically, the increased hepatic production of endothelin 1 and pulmonary production of endothelin B. So it leads to pulmonary eNOS or endothelial nitric oxide synthesis. So this increases nitric oxide. So with portopulmonary hypertension, we're talking about vasoconstriction. Here we're talking about vasodilatation and shunting. So the normal diameter of the pulmonary capillaries ranges from 8 to 15 microns as seen over here, as seen over here. However, this dilates to 15 to 100 microns. So this allows mixed venous blood to pass through the pulmonary capillaries very quickly or even directly into the pulmonary veins. This causes arterial hypoxia. So in summary, you have deoxygenated blood entering the systemic circulation because of dilatation and because of shunting, and you have a ventilation perfusion mismatch. So the three main alterations, you have a ventilation perfusion mismatch, diffusion limitation, and a right to left shunt. So a right to left shunt alludes to deoxygenated blood entering the systemic circulation. So I'll just go through this in the interest of time. And so basically, in type 1, dilatation of the vessels and the precapillary vessels near the gas exchange units. So the hallmark of type 1 is supplemental oxygen increases the PaO2 in this type of HPS. Whereas in type 2, you have larger dilatation of vessels causing AV shunts away. And this causes supplemental oxygen may not help in this case. So clinical presentation, one of the classic symptoms, not only dyspnea, but autodeoxia and platypnea. So what is autodeoxia? When the patient sits up, the patient from a supine to an upright position, they have a drop in the partial pressure of oxygen by 4 millimeters of mercury or PaO2 of 5%. Platypnea is a symptom of increased dyspnea when sitting up from a supine position. Why does this happen? Because the AV shunts in HPS are mostly found in the bases of the lungs. So when you sit up, there's a gravitational increase in the blood flow to the bottom part of the lungs, increasing the volume of the blood that escapes effective ventilation. And this worsens the VQ mismatch. This is in contrast to things like pulmonary edema, heart failure, where it is like PND and orthopnea. Yeah. So this study was quite interesting that basically shows that the rate of decline is 3.7 millimeters of mercury per year, and a non-invasive shunt of at least 20% predicted a slower PaO2 decline. So really, I think you can see that this study characterized them into two types of progression. One is someone who starts off relatively worse but has a slower decline. Oops, sorry. And someone who starts off relatively better but has a more rapid decline. So what are the clinical features? Digital clubbing because of the right to left shunting. And this has a positive predictive value of 75%. So if you have a cirrhotic patient with clubbing, this is taken from one of my patients with permission. It is 75%, a PPV of 75% for a diagnosis of hepatopulmonary syndrome. And of course, this is the telangiectasia. You can see the telangiectasia over here, and because of the vasoconstrictor and vasodilator imbalance. So what is the severity? We already talked about the oxygenation defect for the definition, pulmonary vascular dilatation, and the severity is based on the PaO2. More than 80, 60 to 80, 50 to 60, and less than 50. Or you can look at the pressure when the patient is breathing 100% oxygen. So what is the evidence of pulmonary vascular dilatation? Contrast enhanced TTE, where you see the presence of microbubbles in the left heart. So you inject microbubbles in the peripheral circulation, and you want to count the number of cardiac cycles. And later I have a video to show you how it is. The second thing is actually 99 technetium label macro-aggregated albumin lung perfusion scan. It's a nuclear medicine scan. And basically what happens is normally it's trapped in the pulmonary capillaries, but during intracardiac or intrapulmonary shunting, the aggregates are retained in the brain and in the kidneys. However, the nuclear medicine scan, while it can quantify the shunt, it cannot differentiate between intracardiac and intrapulmonary shunting. The contrast enhanced echo can differentiate because the number of cardiac cycles within which it appears. So this is an example of the radioactive lung perfusion scan. So it's less sensitive, more invasive, able to quantify, and helpful with other cardiopulmonary diseases. Let me just play this video. So in this video, this is a example of a contrast-enhanced echocardiogram. Don't worry, I'm also not an echocardiogram. So when you watch it slowly, you will understand. So slow motion. First beat, second beat, third beat, and look at this, you're starting to see fifth beat, and you can see these contrast bubbles coming into the left heart. So now we know that this is the evidence of the intrapulmonary vascular dilatation. So your diagnosis, so basically, if your patient has platinum autodeoxia, do a bubble scan or perfusion scan. If it's positive, if it's within 3 cardiac cycles, you think of intracardiac shunt. If it's after 3 cardiac cycles, you think of an extracardiac shunt. Then you think of a pulmonary shunt. You look for a large pulmonary AV malformation, and you have to consider hepatopulmonary syndrome. This is taking it from the point of view of a patient presenting with shortness of breath, having platinum and autodeoxia. But for a lot of us, we have cirrhotic patients, and the question we're asking is cirrhotic, does he have hepatopulmonary syndrome? What are the implications and prognosis? So increased mortality from HPS. So we compare patients with HPS and without HPS, we see an increased mortality. And the cutoff of the major, and for those with HPS, the major cutoff with this mortality comes about when the PaO2 drops below 60 millimeters of mercury. So a significantly higher mortality at a PaO2 of less than 60 millimeters of mercury, progressive vasodilatation and hypoxemia without transplant. Because remember, they may have relatively preserved liver functions, but their lung condition is driven by their livers. So expedited transplant for patients justifying mild exception. So median survival of 4.8 months. If you look at cirrhotic patients, 4.8 months with HPS compared to 35.2 without, and 24 months compared to 87 months without in the same studies. And our mortality rate was double, adjusting for age, sex, race, and MEL score. So really, I think if they have you screen them, they may be asymptomatic of dyspnea. And if their survival is actually quite poor without a transplant, and they will either die from the HPS or from their complications of liver disease. However, if you transplant them, they generally can get a good outcome. Your management options, your only treatment is liver transplant and supplemental oxygen. Some people have described coil embolization for discrete vessels, but really in very highly selected patients. There was this recent study that looked at tips for the management of tips for the management of for hepatopulmonary syndrome. Now, personally, I don't know whether this matches the pathophysiology, but their study did show some relative benefit. But this benefit was only seen early and by 12 months from the transplant. Really, so the four different studies are shown in green and the various shades of blue, and this is early, 3 months and 12 months. By 12 months, the effect had weaned off. So really, even if TIPS works and it may not be a definitive therapy, you still need to consider transplantation. What are your transplant considerations? So basically, this was comparing pre-meld and post-meld. So 2002, from what I understand, is when UNOS introduced meld exception for hepatopulmonary syndrome, and when they introduced meld exception, the survival, the 1, 3, and 5 year survival actually improved significantly for patients with hepatopulmonary syndrome. What is the cutoff for which the mortality is higher? It is a cutoff for less than 45, the PaO2 of less than 45 millimeters of mercury. So below 45, you really should be asking yourself, should I be doing this? However, in certain centers, and this study, actually, the report showed that while they had a higher mortality as compared to the other patients with hepatopulmonary syndrome, they still had an improved outcome. And the difference was seen at 2.6 years. So I think the conclusion that we would say is that if the PaO2 is less than 45 or 50, they may still benefit from a transplant, but you really need center-specific excellence. And really, I mean, consider transplanting these patients at a center that really has experience in this, given that it's a relatively uncommon condition. But I think, so really, I think the thresholds 80 to 60, and then less than 60, they really should be getting meld exception points. And less than 45, you should be, or even less than 50, you should be asking yourself, should they even be getting a transplant? Is it futile given our expertise or what we are doing? So what are their post-transplant outcomes? Better survival since meld exception was put in place, and patients with more severe intrapulmonary shunting. So if you look in this study where they in the post-meld era and pre-meld era, similar to the other data I presented, there was better outcomes. But if you can see here, so on 100% oxygen, patients who had a higher PaO2 as compared to patients 100% oxygen with a lower PaO2 had a more significant benefit. So meld exceptions in UNOS, PaO2 less than 60 gets 22 points. I'm not sure if this is, I'm not familiar with UNOS. I'm not from US. I don't really keep myself up to date with UNOS. In Singapore, patients with hepatopulmonary syndrome get a meld exception of 16 points, but they do not go up further. But HPS does not correlate with disease severity. So perioperative management, we monitor mixed venous oxygen saturation intraoperatively, KIV veno-venous bypass, early extubation and chest physiotherapy, face mask to target SpO2, prevent excessive fluids, inhale pulmonary vasodilators, and resolution can take months, but it is more likely to resolve. Now, this is a very nice diagram, and I've used this diagram on clinical practice when when we transplanted a patient who was struggling, which I'll discuss later. So basically, what are your strategic measures you can take? Trendelenburg positioning, inhale ipoprostenol, inhale nitric oxide, methylene blue, and embolization of pulmonary vessels, and ECMO if you're still struggling. So these are the steps you can take. I recommend everyone to have this if you have a patient and with your anesthesia team. What are the rationale of these positions? So Trendelenburg positioning, you use gravitational redistribution, inhale vasodilator, so you dilates normal vessels, redirecting flows from your abnormally dilated segments. Methylene blue is a guanylate cyclase inhibitor, again targeting the pathophysiology and of course embolization of the lower lobar vessels. And ECMO just oxygenates the patient until the patient bridges to recovery. Same diagram again, but what I wanted to highlight was this figure on the right, where basically we see a rate of improvement of 6.5 millimeters of mercury per month. And, and this was faster in patients with a 10 greater pre-transplant autodeoxia. So patients who had autodeoxia that worsened more significantly, the drop was greater, actually recovered faster in this study. So the authors hypothesized that this predicts more rapid improvement because of favorable vasoactive factors emanating from the transplanted liver are gravitationally favored to reach the lung bases. So if it's predominantly a basal, very anatomically distributed, then these factors also more preferentially go into the lung bases. But what can we see from this study? Improvement in DLCO at 11% per year, improvement in PaO2 mean at 6.5 millimeters of mercury per month, improvement in 6-minute walk distance at 190 meters per year, and median time to normalization of PaO2 was 149 days. So really it gives us some idea of the post-transplant course of this patient. And the improvement post-transplant, I think this is a very nice cohort. It's a meta-analysis of 22 patients. I think what I wanted to highlight is at 6 months, 90% had resolution of hepatopulmonary syndrome, and at 1 year, 100% had resolution of hepatopulmonary syndrome. So really, I think this is very encouraging for the condition. Now, finally, we come to the case presentation. 47-year-old male forklift driver, ex-IV IV drug user, given up many years ago, and hepatitis C liver cirrhosis, genotype 3. We use soft DAC riba, and he failed. Struggling in decompensated cirrhosis. At this point, we were all arguing about the MEL purgatory. So MEL 12, but he was noted to have hypoxemia. And he had digital clubbing and spider nevi. So this is what triggered us actually. And no mucosal telangiectasia. Saturation was 90% on room air standing, and no significant change on supine. So we didn't really see autodeoxia in this patient. So this was his blood gas. You can see a PaO2 of 69.9 and an AA gradient of 47.1. His expected AA gradient was 16 millimeters of mercury corrected for his age. So he had a reduced DLCO. And no visible AVMs. We did a coronary angiogram, which was generally normal. I mean, there was a left atrial AV fistula, recurrent left atrial to coronary sinus. So when we did a contrast echo, we had bubbles in the left heart after 5 cardiac cycles. We also did the nuclear medicine scan, which showed abnormal radiotracer activity, and the shunt fraction was 33%. So the diagnosis was hepatopulmonary syndrome, and basically he was monitored on our transplant wait list, deceased donor liver transplant, not living donor liver transplant, given MELD exception points. He was on home oxygen therapy. PaO2 dropped to 58 prior to the transplant. Home oxygen therapy. He underwent a DDLT, and then post-transplant self-Velvox post-transplant for Hep C, and he was weaned off. Now, we struggled a bit, and I think we've published this data about this case actually, where we were struggling and we were using that algorithm, Trendelenburg position. We didn't have to go to ECMO, but we had difficulty with his oxygenation. And so this is where we used pentoxifylline. We were on non-invasive ventilation because we were trying to avoid reintubation for him. We started pentoxifylline, and which apparently, now I'm not fully convinced that the pentoxifylline was the one that did it, or was it just, the new liver and his hepatopulmonary syndrome improving? But I think this is a strategy that I did one. I will not cover hepatic hydrothorax and SBEM in the interest of time. So I've just left a summary slide here, which I think Dr. Sanjaya will share with you. But maybe let me just summarize, because we are already at time. So, pulmonary complications of liver disease present as significant disease modifiers to the trajectory and outcome of liver disease. A good understanding of the pathophysiological basis. I think we have seen very earlier on in my career, we used to say, oh, let the cardiologist, let the anesthetist settle this. But if you're managing these patients, I really recommend that you have a good understanding of the pathophysiological basis of disease and the ability to stratify and prognosticate your patients, so you can have a good conversation. And actually, in our center, especially before transplants, and we list someone before a living donor liver transplant, we have an anatomical evaluation and we have a physiological evaluation to go through that. A portal hypertension drives these conditions, but the pulmonary consequences are contrasting. One is more vasodilation, one is more vasoconstriction, and it's imperative to be treated in a multidisciplinary team with adequate expertise, and careful preparation for transplant is important. With that, thank you. I'm happy to take any questions. And before I take questions, I'll just a shout out. We're organizing the APASL Single Topic Conference, Asia Pacific Conference on liver cirrhosis in July 2026. And this is my invitation to everybody to attend this. This will be in Singapore, and we hope to see you all there. With that, thank you.
Mark, thank you so much. That was a masterpiece talk covering entire spectrum of hepatopulmonary syndrome, portopulmonary syndrome, and a little bit of hepatic hydrothorax that you covered today. You can unshare your screen now.
Okay.
Awesome. Before I begin, I would like to thank you for this wonderful talk, and then thank our audience who has been glued to this entire session since from the beginning, and a lot of people attended from around the world. I want to also thank the audience for the support to Inersis. We have now crossed 21,000 subscribers in our YouTube channel. So a big shout out to our audience who has been constantly supporting us for this. With that, I'll open this talk for some questions. But the one question that I would like to ask before someone else take over is, in patients who has severe hepatopulmonary syndrome, let's say PO2 less than 45, likely they may have a bad outcome, and most centers won't do a liver transplant only. But there are centers who have ability to do multivisceral transplantations. I think these are the patients who might still get benefit with a liver and a dual liver lung transplantation. In fact, our center does it, and we have a patient right now. In fact, we've been evaluating for a potential dual liver and lung transplantation. Is that something you also think in your country as well?
So I think it is very difficult to say. So, for example, in our center, our country, lung transplantation, multivisceral transplant is even more difficult. I think if you look at the deceased organ donation, and I know you practice in America, I think America is between 38 to 40 per million population. Where I come from in Singapore, our per million population of organ donation is about 3. If I'm not wrong, 3.21 at the last IRODAT statistics. So we really get very, very few. I think lung transplantation, we see maybe, I don't know. I can't even remember when I last encountered a lung transplantation. So, and then the waiting list, you see, even for us to have a simultaneous liver kidney, is very challenging because the kidney waiting list is out of proportion to the liver. So because of these local factors. Now, the second thing which I touched on in my talk, even though isolated liver transplant has a high morbidity, high mortality, compared to not transplanting the patient, it is still better. The 2021 study demonstrated that. So I would say that in our center, we would be cautious. But the argument could be had that if it was a living donor liver transplant, and the patient in a center that had appropriate anesthesia, cardiology support, you could consider that living donor liver transplant, perhaps with more VA, ECMO support, all these kinds of things. Now, also then I think it comes to your transplant regulations. It's the same argument we have with HCC. What cutoff of risk would you take? So it's
Yes.
not just, yeah, it's not just the equity, it is the comparative risk.
Yep. Thank you. And now it's open to some questions. I see Dr. Wani. Dr. Wani, if you want to ask that question, introduce yourself, keep your video on.
Oh, this is a very excellent presentation, and I'm so glad that I'm here to listen to all of this. I have a couple of questions, like three questions for you, Dr. Muthiah. So the first one is, are you able to qualify how well a patient is going to do post-transplant based on the degree of the extrapulmonary uptake after an albumin scan? Number two question is based on the RVSP. Can you what value should I kind of like look out for to be able to prompt a left heart cath for a patient? And is it possible for you to be able to kind of like have an idea of what degree of the portopulmonary hypertension the person may have based on the RVSP? My third question is if you can like just tell me again why the venous bypass for this patients, and do you use it for like everyone or just for those that had like a severe portopulmonary hypertension, or sorry, moderate to severe portopulmonary hypertension?
Okay, so I think the first question was from hepatopulmonary syndrome. So I
Yes.
think the study that so again, there are very few studies that give you the post-transplant outcomes in very great detail. People generally report 1 year, 3 year, 5 year survival. But the hepatology study, I think if I'm not wrong, it's a Canadian study, the Sun Zhao 2024 study. So they basically said that with the autodeoxia, if the patients had a greater drop in autodeoxia, they had a faster recovery. The other study was the study in 2021. This showed that if there was worse shunting, meaning that if the PaO2 was less than 300 millimeters of mercury on 100% non-rebreather mass, meaning that the shunt fraction would be higher. Your question exactly. The outcomes were generally slightly worse as compared to those who had a better shunt fraction. But if you look at all the studies comparing the resolution, they did not stratify these into whether the shunt fraction was worse or the shunt fraction was better. So I don't think we can conclusively say just we can prognosticate those patients on the shunt fraction. The only data we can use to prognosticate those patients would be the PaO2 of less than 45 millimeters of mercury or less than 50 millimeters of mercury. So I've dealt with your first question.
That's right. Thank
Now,
you.
now, dealing with your second question, what value? So if you when your cardiologist does the echocardiogram, again, they're going to estimate. They're not going to measure the RVSP or the PASP. They're going to estimate it. And they're going to estimate it based on the tricuspid regurgitant jet. And so the value that is key is the TV jet of 2.8 meters per second. And it's not just for portopulmonary hypertension, it's any pulmonary hypertension. The other thing that to look at is also some of the echocardiographic features that I highlighted just now. Let me just go back to my slide. But meanwhile, so I would say that because your tricuspid regurgitant jet may not always be seen, whether it's because of ascites, obesity, and all these things. So when you send a patient, at least when I send a patient for an echo, my cardiologist will tell me low probability, moderate probability, or high probability of pulmonary hypertension. And so if it's moderate or high, I will go ahead. However, if I have a low index of suspicion, meaning a patient clinically has a pulmonary component of the loud P2, right ventricular heave, venous pressure is elevated, I'm worried I may sit down and have a discussion with my cardiologist whether the patient would benefit from a right heart catheterization.
Okay.
Yeah. Yeah, I think that was the RVSP. So if it's intermediate, and perhaps maybe I can share screen. Let me just share the screen for you. Can you see this?
It's still, yes, I can.
Yeah, so TR velocity less than 2.8, less than 2 echo categories, low risk. This is actually from the echo guidelines, the cardiology guidelines. If it's more than 2.8, or if there's echo categories, intermediate or high risk, these are the categories that they look at.
Okay.
Yeah. Have I answered all the
Yeah,
questions?
you did. I think the last question was about the venous bypass. What
Yes,
category
veno-venous
of people?
bypass.
Yeah.
Yeah. Okay. So how does the veno-venous bypass help in that it limits the reperfusion injury? Because when you're having veno-venous bypass, it's from the prehepatic is coming into the IVC. So what is really happening is that there's no clamping. So in transplant, you have a total cross clamp or partial cross clamp in general. So they cross clamp the IVC. Now, most surgeries do a partial cross clamp these days. There are still some anatomical or surgical factors where the surgeon may do a total cross clamp. But you saw in my patient, the case that I presented, at reperfusion, he collapsed and he arrested
Yeah.
because of right ventricular failure. So in my program, after this case, we've put in place that we would actually prefer having veno-venous bypass for most of our portopulmonary hypertension. And I think if you look at the ILTS cardiovascular group, some people even advocate VA ECMO in most of these cases, because then you have a standby for the oxygenation as well. But I think your biggest risk is in at reperfusion. And so we discussed this. So we actually discuss it quite intently. We're having a lower threshold, especially in patients. I mean, now we are transplanting more and more patients with meso. We're transplanting more patients with cardiovascular disease. So there was one point we never used veno-venous bypass, and now we're starting to see more of it.
Okay. Thank you so much.
Mark, those questions. First of all, Dr. Ogunao, the questions were very important and very pertinent, and the answers were also very, very educational, and really liked it. Thanks, Mark, for that. Let me introduce Dr. Prasoon Jalal, who is a professor at Baylor University, has a question. Dr. Jalal, please.
Hey, no, Mark, this is a great, elegant presentation. Hey, I have a question. Have you seen any patient with, I'm sorry for background thing, any patient with both combination of HPS and PoPH? And how do you handle that?
Yeah, I recall one patient that I actually remember this that had a combination of HPS because we diagnosed the portopulmonary hypertension, but the patient had unexplained hypoxia, and we actually did the contrast echo and it was negative. But we couldn't find any other reason for this persistent hypoxia. So my cardiologist actually did a transesophageal echocardiogram together with the contrast echo, and we managed to, and then he demonstrated that in more than 5 cardiac cycles. So I mean, I have a cardiologist. I am blessed with a cardiologist who actually has a huge interest and understands the liver transplant. Now, for this, of course, I would say the treatment we would treat both like individual conditions. We would still consider the endothelin receptor antagonist. Unfortunately, in Singapore, this patient would, no matter what, he wouldn't get additional MELD exception points. He would get a MELD exception of 16 points. But in general, we would bridge to transplant this patient. I personally find the HPS goes off relatively quickly, or, it will go off within a year. And worst case scenario, I'm dealing with a portopulmonary hypertension. But most of our patients with very close management with the cardiologist, we can slowly start to wean the pulmonary artery hypertension treatment or yeah. So I would say that we treat them individually, we risk stratify them individually. Whether this is correct or wrong, I'm not sure as well, because one arm is vasoconstriction, one arm is vasodilation.
Now, when you ask for the male exception points, which one you predominantly choose?
Both are 16. So for me, it doesn't matter.
I see. Well, in the US, I think we get MMAT, which is the median male score at transplant with these conditions. So much higher male score, exception points here.
Great. No, this is fantastic. Thank you. I totally agree with you.
Yeah, thank you.
Thanks, Rasoon. And may I invite Dr. Benedict Maliakal from Nashville, Tennessee.
I that was a great comprehensive talk, and learning the physiology and pathophysiology is so important. I think the main thing, like you said, is you have to be blessed with a good cardiologist or pulmonologist who does not impose his views and is a team player, because I've had that happen to me quite a bit. And in the previous question, Dr. Jalal asked, there are some patients, I saw a patient some time ago who we diagnosed a HPS, but shortly after transplant, I think the pulmonary hypertension became evident. So it was kind of masked, or we didn't diagnose it because the combination is not suspected by most people. And so the HPS goes away, and then the pulmonary hypertension starts like after transplant. And, that was a pretty challenging situation. Um, the problem with HPS is to keep them going till they get a transplant. And so, garlic and pentoxifylline and methylene blue, etc. I mean, what do you have some kind of a protocol for these patients who are suffering for sometimes 2, 3 years um, before they can get a transplant because of the MELD exception is not very good for these patients?
So if you saw in the case I presented, the obvious question would have been, why didn't I treat the patient with Vosevi pre-transplant? And that was the exact reason why I wanted the MEL score to go up. I wanted the MEL score to go up because he was suffering. His PaO2 had dropped to 58. And so, these are the considerations we have to balance. But I agree, actually, the only viable treatment in the outpatient setting is supplemental oxygen. And we find, you see these patients, they come in for transplant evaluation, they're a little bit short of breath, at first they're a bit asymptomatic. 1 or 2 years into it, they're on supplemental oxygen, the oxygen is going up. Both you and the patient are getting stressed at every clinic visit. I think it's challenging. And then once they get admitted, of course, you start struggling. I think one other thing I would highlight in this patient, he was a smoker, and we convinced him to stop smoking. So some of the other pulmonary rehabilitation things, but I really don't have anything specific. One other thing that I would mention, and maybe I didn't include in my talk, is that when, at least in my center, when we transplant patients for HCC, we tend to use especially higher risk HCC, like the first case presentation, outside UCSF within UNOS-DS. We tend to use mTOR inhibitors as immunosuppression, but in portopulmonary hypertension, sometimes in hepatopulmonary syndrome, but always in portopulmonary hypertension, we never use everolimus because we're just so scared of anything tipping the patient over. And everolimus or your mTOR inhibitors are associated with interstitial lung disease, pleural effusion, some pulmonary complications. So we do tend not to use everolimus in those patients.
Right. And just something new that came about in pulmonary hypertension. I don't know if the activin inhibitors are they going to be useful in portopulmonary hypertension?
I'm not sure. We generally, our protocol starts with PDE5 inhibitors, and then we move on to ambrisentan, because everything else is out of the affordability of our patients. I have one patient from overseas because our center takes patients from overseas on macitentan. But I think that is about my general. I think there's a lot of investigational therapies. We extrapolate from the pulmonary arterial hypertension, the primary PAH studies, and then they come over to our portopulmonary hypertension patients.
Thank you.
Thank you. May I invite Dr. Hilal Tobias from Lenox Hill Hospital? Dr. Tobias, please. Dr. Tobias brings a vast experience of hepatology from the time, maybe, the three decades or 4 decades of experience. I don't know. Dr. Tobias, please. I think we're going to move on to then another question while I'm getting Dr. Tobias on board. But let me ask you one question here. Now, you mentioned in your talk about the role of tips in a limited role, of course, in tips in the hepatopulmonary syndrome primarily. Now, for both portopulmonary and hepatopulmonary syndrome, the primary diagnosis has to be portal hypertension. That's the driver of the condition. So you're treating portal hypertension and may have a potential beneficial effect, although you're not completely, getting rid of the portal hypertension is still there. Now, do you think the same could be applied in portopulmonary hypertension, or is there any caveat for that?
I would not do a TIPS for a patient with portopulmonary hypertension because you would increase the preload on the right heart and you would tip the patient into right heart failure. In fact, our criteria for TIPS is that when my radiologist goes and measures the free pressure, he also measures the RA pressure. I get a phone call on the RA pressure before we say go ahead with the TIPS. So we are very cautious about that because I mean the RA pressure, your mean PA pressure, when your radiologist or your cardiologist is in, they can measure these pressures. So we should not be doing that. The preload on the right heart would tip the patient into right heart failure. Hepatopulmonary syndrome, I struggle with the pathophysiology because we assume that it is the shunting from the portal hypertension is driving the factors that is causing the vasodilation. So technically, TIPS is the mother of all shunts in the liver, right? So yeah, but at least the data, it's the latest study I could find, so I had to put it up.
That's a very important point, and I think for our trainees and everyone else as well, to ensure that where to use judiciously in the event that choosing tips for between these two conditions. So while I'm waiting for more questions, one other question that I have is in hepatic hydrothorax. This is a difficult disease to treat, hepatic hydrothorax, especially those who are requiring multiple taps. What's the strategy? Of course, we didn't learn a lot because of the time constraint today, but what's the strategy you have in your country, medical management, and any kind of other options that, and also a pathway for transplant in these patients?
I think for us, we assume we take hepatic hydrothorax like diuretic intolerant or diuretic resistant ascites. The primary management is the management of, like, for example, ascites. Other than if the patient is symptomatic, especially with respiratory compromise. If they're symptomatic cardiorespiratory compromise, it's very different. Save the life before you stick to your dogma. And then after that, if they have no cardiorespiratory compromise, it would be fluid and salt restriction, diuretics, and then of course consideration of TIPS. And I think these are all the step-by-step management. We try and avoid pleural drainage unless it cannot be avoided. Patient is symptomatic. We try our best to avoid pleural drainage. One of the other things I wanted to talk about, I mean, if I had had the time, was actually spontaneous bacterial empyema. I think just a point for everybody out there. I think most of us are very familiar with ascites, even hepatic hydrothorax, patients with ascites, right-sided, you do a diagnostic thoracocentesis, you suspect. But I think always remember that when a patient comes in with decompensation, fever, and sepsis, even ACLF, and you have a patient with a hepatic hydrothorax, always consider spontaneous bacterial empyema. That means infection of the hepatic hydrothorax as one of your differentials. So consider a diagnostic thoracocentesis.
You use the same criteria for acidic fluid SBP for this SBE, spontaneous bacterial empyema.
Yeah, so generally we are looking for transsudative pleural effusion. I mean, the serum to pleural fluid albumin gradient greater than 1.1 gram per liter or 11, depending where you use it. Yeah.
Okay. So we were talking about this, for the hepatic hydrothorax in US, UNOS has a guidance for giving MEL exception points now, and their guidance is that at least 1 liter of fluid drainage and 4 different occasions in 6 weeks time period. So that's
So I think,
yeah.
MELD exception is a very controversial topic. So I come from a small country. My country is about 6 million population. Our per million population donation is about 3. So really, our waiting list is quite long, but we don't have the volume to calculate, the comparative benefit. Our major MELD exception is liver cancer. And, I mean, we have a high prevalence of hepatitis B, so we see a lot of Hep B associated liver cancers. I think it is very challenging and to assign MELD exception points. So in Singapore, generally, if someone needs an exception, they get 16 because they get HCC is 15, so you jump above all the HCCs.
Yeah.
So the assumption is the mortality is higher than a HCC mortality. But of course, we're not like US where you take the HCC into account. For us, a bordering on UCSF out is the same as almost a very close to Milan in. So really, I think it is challenging. We don't have the data. My view is globally, we should be able to assign risk scores and as a global community, assigning risk scores. So then different countries can use these metrics, especially small countries, countries that do a lot of LDLT can assign these metrics to decide how to assign MELD exception points. But that will take a lot more work.
That's a very good point, actually. I think this kind of forum that we have in NETSIS or similar kind of forums, these are concerns that we should raise, and then we should, put our heads together to come out with a consensus statements that might potentially help to programs like your country and some other countries to come with a consensus plan as what would be the standardized MELD exceptions. Because US, we're giving much higher points to this, and then your country is giving only 16 points. So probably there is a disparity, and the patients are getting not that disadvantaged, basically.
May not be because a patient with a MEL score of 16 or 17 actually doesn't wait as long as a US patient with a MEL 16 or 17. Whether it's because of living donor liver transplant, once they are a bit higher, people start pushing more to get the families in. Again, it's very variable. So that's why I say this it's a very difficult nut to crack, and it needs more than just, our traditional scientific metrics.
I see. I think that's a very good point. Well, with that, thank you very much, Mark. This was a wonderful talk. And with your permission, we'll put it on our website. And then people who did not attend today, they can come back and listen to this talk and learn from it. This was a really fantastic talk. And thank you to the audience as well, and for their continued support. And we'll look forward to see you all again in 2 weeks with another interesting and a fantastic talk. Make sure you look through your emails when we're sending it out, so that you all know. Thank you very much again.
Thanks for having
Thanks
me.
you.
Thank you. And
Thank
your
you.
transplant
Thank
talks are
you.
doing very well. I listened to them.
Yes, thank you.